Last but certainly not least this week, we're going to talk about the elderly or geriatric population. There are some unique problems that we encounter with the elderly with regards to medication use. We know that medication use increases fall risk, and elders are taking more medications than ever. Polypharmacy, many, pharmacy, drugs. So it's defined as many drugs, correct? So what is many? Well, some sources will say 5 and some say 6. It's also defined as when a patient is taking more than one medication for the same condition. This sometimes happens because a elder may go to see more than one doctor for the same condition, and one provider doesn't realize they're taking a medication or doesn't distinctly tell them to stop taking the medication. So there's a lot of reasons that this happens, but polypharmacy can lead to not just increased falls, but increased length of hospitalization, increased occurrence of hospitalization, increased incidences of drug-to-drug interactions or drug-to-disease interactions. They also have greater risk from drugs due to decreased renal and hepatic function, lower body mass, and sometimes decreased mobility. Yet, in spite of this, 75% of the elderly take one or more prescription medications, and 25% take more than 5 medications on a regular basis. The elderly typically take at least 3 over-the-counter medications as well. So non-compliance and non-adherence can be because of cost or a lack of understanding, maybe communication barriers, differences in doses, maybe there's inconvenient scheduling, and sometimes social isolation. We know that they often have decreased fluid or nutritional intakes, many comorbid conditions like maybe diabetes and hypertension or COPD and diabetes. So because people are living longer, of course, you can expect to see more medications for more comorbid conditions. And the other problem that you may notice is that patients are sometimes affected by their sensory or their motor deficits. So those are important things that we have to take in consideration. We will also see this population of people that save medications because they are kind of saved. That's what they do, save, save, save. Maybe they borrow medications or share medications with their loved ones or with their spouse. And then, of course, self-medicating. So when we look at this population and we look at the table in your book, table 3.3, we can see that these systems, the physiological changes that occur in the elderly patient, affect their ability to metabolize, absorb, or excrete the medications. I'm not going to read this chart to you, but with the GI, what this means is that for the drugs, sometimes the drug is essentially unchanged. And so that can be an issue. The cardiovascular output, it affects everything because it not only absorption, but how do we get that medication to the cells? With the liver, the hepatic, as the liver decreases metabolism, remember back earlier this semester when we talked about the phase 1 and phase 2, phase 1 being that oxidative phase of the metabolism, well, that's decreased in the elderly. Now, phase 2 is not so affected by aging, but because phase 1 is affected, there are some major drug classifications that are affected, the entire class. So this, when we combine it with the decreased hepatic blood flow, means that the amount of drug that's extracted by the liver for metabolism during the first pass is decreased. Therefore, there's this increased bioavailability of the drug. So that results in for us that lower doses are required. you look at the renal, and you're going to read about creatinine clearance with regards to pharmacokinetics. It's going to be in your drug guides. You're going to see this. Well, creatinine clearance decreases about 10% per decade after the age of 40 in 65 to 66% of the population. So we often will have a serum creatinine drawn. That's part of our chemistry panel. But serum creatinine is not really a good indicator for renal function in the elderly, because serum creatinine, where it's different from creatinine clearance, serum creatinine is a product of the muscle breakdown, and the decreasing muscle mass in aging could show a normal serum creatinine in the elder, but they have decreased renal function, so that creatinine clearance will be high, and that's a urine test. And frequently we'll see that ordered as a 24-hour study. So that's really what's preferred and what's needed. This cardiovascular, gastrointestinal, hepatic, and renal, all of these physiological changes are in addition to the elderly patient's decrease in total body water. So from the age of 20 to the age of 80, your total body water volume decreases by about 15%. So that means that hydrophilic drugs must be given at lower doses. Because we also have a higher fat content, men go from about 18% to 36%, and women go from about 33 to 45%. We also need lower doses for hydrophilic drugs. So the rule of thumb with medication for the elderly is that we start low, we use the lowest dose possible, and we go slow, meaning that we don't increase it very rapidly. We increase it very gradually, if at all. So in the pharmacokinetics, we're looking at this delay in absorption, and that's dependent upon the fluid and the nutritional status of the client. We know that compound drugs are affected by this slower active transport process. Gastric pH is less acidic, and gastric emptying is slowed. So when we look at why is this happening, the movement through the GI tract itself is slowed because the blood flow to the GI tract is reduced by 40 to 50%. And then the surface area is also flattening. Those villi and microvilli are being flattened out. Oftentimes, you will see that a patient may have a constipation, and that happens for multiple reasons: lack of fluid, poor fiber in the diet, or not enough fiber, maybe dentation. Those sort of things are an issue. But they will use laxatives, which will actually accelerate the GI motility. So then we have less absorption because it's gone through the system too rapidly. As we continue through the pharmacokinetics with the elderly distribution, we see a total decline in the total body water and the lean body mass, and those affect distribution. Again, that increased fat content gives us an increased risk of toxicity because we're not moving these things through the system or getting rid of it as quickly. And so the liver also starts to reduce the amount of proteins. And so this means there's a decrease in the protein binding. So there's an increase in the circulation of the free drug and that bioavailability. I think I might have mentioned that a couple of slides back. But when we look at this in the geriatric, albumin levels we know are decreased. And albumin being our most common protein, that binds to those acidic drugs. So albumin is really important for us to monitor in our geriatric patients in terms of labs. When we look at metabolism, that aging liver does not function as well. The decreased hepatic mass, those fewer microsomal enzymes being produced. We've got that decreased circulatory effectiveness. We've got age-related changes with the renal function in terms of our excretion. And that's the single most important physiological factor that results in our adverse drug reactions. is the decreased glomerular filtration rate, and they have fewer intact nephrons. So excretion isn't occurring, so you get buildup, you get drug toxicity in these patients, and it can happen pretty quickly. There is a list of medications that it's called the Beers list or the Beers criteria. This was developed in 1997, and these drugs are potentially inappropriate for use in persons 65 or older because they're either A, ineffective, or B, they pose an unnecessarily high risk for the elderly, and a safer alternative is available. There are about 48 medications or classes to avoid, and they're also included in the Beers criteria a list of 20 diseases or conditions with certain medications that we're specifically to avoid. One of the pitfalls of the Beers criteria is that this extensive study is a great study, and it was the first of its kind, but it was done using a retrospective record research and the data from nursing home patients. Because of this, in 2010, there was a new research study done that revealed what's called the ZHAN, Z-H-A-N criteria. And the ZHAN criteria reevaluated the Beers criteria, but it evaluated it on community dwelling elders. So it narrowed that to 11 medications to always avoid, 8 that are rarely appropriate, and 14 that may have some indication but are potentially inappropriate. So you will see prescribers that use the Beers criteria, and then you'll see others prescribers that use the ZHAN criteria. However, when we think about the pharmacodynamics in the geriatric patient, we know that there's changes in the concentration and the response relationship. There's also changes in the receptor sensitivity because of the aging of the central nervous system. So drugs with anticholinergic side effects are particularly notorious for reducing adverse effects, and they should always be avoided if at all possible. We'll talk more about that, and we'll give you a little mnemonic that'll help you remember those once we get to those anticholinergic drugs. So just kind of keep that tucked away in the back of your mind until then. We always want to start low and go slow, like I said before. And so you're not prescribing, but it's important for you to realize this as you look at the norms and the normal dosages and what you're going to be giving the patient. Because remember, you're the nurse and you're going to be the one at the bedside administering that medication. So a couple of other considerations. These medications that are listed here are pretty problematic. Analgesics, including the NSAIDs and the opioids. NSAIDs, lots and lots of patients take them every day. So caution with that. Our anticoagulants, anticholinergics, antidepressants, antihypertensives, cardiac glycosides. Look at this list. Who takes these medications? Our geriatric patients. So we always want to be monitoring this. Every drug must have a clearly defined indication. And if you're going to be working in the long-term care setting, this indication really, by legislation, needs to be included in the provider's order. So be sure that you're looking for that or asking for that. It's going to be right there in the order. Patient education is imperative. A lot of times patients are non-adherent or non-compliant because they don't understand the importance. And they also don't understand polypharmacy. Sometimes they think more is better, or I had this medication, but it caused this side effect, so I'll go get an over-the-counter drug or over-the-counter medication to counteract that. So patient education is key. And as always, a comprehensive medical history is very necessary, including those over-the-counter and those herbal medications. So I encourage you to call, text, email, get a hold of me with any questions, and I look forward to seeing you soon. Take care. We'll see you later.